Good afternoon, and thank you again for this kind invitation to speak on MMA embolization for chronic subdural hematomas. These are my relevant disclosures, primarily relating to my role as co-PI for the membrane clinical trial. Briefly going over the pathophysiology of chronic subdural hematomas. These represent a combination of repetitive injury and response to injury. Basically, after a subdural hematoma forms due to trauma, there is an inflammatory reaction that leads to proliferation of fibroblasts and creation of new inflammatory or leaky membranes that are very fragile and keep on rebleeding and forming a chronic subdural hematoma. So we have this cycle of traumatic injury with initial subdural hematoma followed by inflammatory activation, angiogenesis, development of very fragile vasculature, inflammatory membranes that keeps on bleeding and repeating the cycle. And if you look at the inflammatory mediators that are involved, these are the typical host of inflammatory mediators as we see in any response to inflammation, interleukins, vascular endothelial growth factors, etc. And it is the interaction of these repeated inflammatory process in cascade that leads to the development of these chronic subdural hematoma membranes that act as a nidus for repeat bleeding and further inflammation. If we look at it under histology, this is a histological section of the outer membrane of a chronic subdural hematoma, which typically has these fibroblasts surrounding an inner layer of erythrocytes. Epidemiologically, this is a pretty significant problem, especially in the elderly. This is considered a sentinel event because once it happens, it leads to a downward spiral in the elderly because of causing significant dysfunction into day-to-day activity. Earlier incidences were reported at 1 to 2 per 100,000. This is in the 60s. And more recent data shows that this number is actually pretty high, 20 per 100,000 people overall, but exceedingly high in the 70 to 79 age group at 76 per 100,000, and over 80, 127 per 100,000. So as our population ages, this becomes a very significant problem with expected cases over 200,000 in the coming years. On the literature, again, we see that there has been a significant interest in treatment of these chronic subdural hematomas utilizing MMA embolization. A significant interest and increase in the recent years. And these are the clinical trials that are posted on the clinicaltrials.gov website evaluating the role of MMA embolization, utilizing different embolic materials such as squid from bald, NBCA true film, which is from Cerenovus, onyx particles. And these are being conducted all over the world, US, Europe, China, Iran, Sweden, Germany. There are currently two main modalities of treatment: non-surgical medical management or surgical intervention. Non-surgical or conservative management also employs the use of steroids, antifibrinolytic agents, and statins. And all of these have been shown to have some efficacy in clinical trials. Surgical interventions include either less invasive techniques of twisted craniostomy, SEPs, versus the traditional craniotomy or burpos. And the decision to for conservative versus surgical really is dependent on the patient's symptomatology and presentation, with a conservative approach for relatively mild symptoms or asymptomatic symptoms, and treatments involving discontinuation of anticoagulation and antiplatelet therapy, which are important considerations in the elderly, as there is a host of comorbid conditions such as atrial fibrillation that require these treatments, and stopping these therapies can be harmful in other ways. So that's why it's important that we do come up with other treatments that allows us to continue these treatments while breaking the cascade of injury and inflammation that leads to chronic subdural hematomas. Obviously, symptomatic patients with symptoms of cerebral compression require surgical evacuation. Now, The goal is to understand if MMA embolization can be offered as either a primary treatment without surgical intervention or can be offered in conjunction with surgical intervention as an adjunctive therapy. The scope of MMA embolization for subdural hematoma before we started our own practice, and we went over the literature and epidemiology, but we wanted to understand what is the scope in our own population. And as a first step, we looked at all the ICD-10 codes that describe this disease. And there are several of them covering both non-traumatic and traumatic subdural hematomas with or without associated comorbidities. We looked at our own hospital over the last 3 years using these ICD codes. And we find that traumatic subdural hematomas were the most common. We're a level 1 trauma center, so this is not surprising. We looked at the DRG codes that were associated with these ICD encounters. And we looked at the non-traumatic subdural hematoma, which were at 42% because that seems to be the first break in defining chronic subdural hematomas. We don't want to be treating traumatic subdural hematomas acutely with middle meningeal artery embolization, certainly at this point. The next step was to determine what was the incidence in our population. And 3 key variables of good population studies are a well-defined population geography, which in this case is our 4-county primary service area in the northern part of the state in West Virginia, where our hospital is located. Another critical element is having significant access to the population and reliable markers of the disease. To determine the significant access to the population, we looked at all these diagnostic codes and DRGs and determined what percentage of patients having these ICD codes from our population come to our hospital. And this can be done by comparing the domicile of the patient to where they were treated. Data is available on the Department of Health and Human Services website because all counties are required to report these ICD codes. So we determined that 97% of the patients with these ICD codes and DRGs come to our hospital, which is a fairly high indication of market penetration, and also implies that if we make any estimates as to what is the incidence of the disease in our primary catchment population based on what comes to our hospital, it should be very reliable, up to 97%. And we can account for the remaining 3% and come up with an incidence in our catchment population. We will not be able to do this if we were only treating 30% of these patients from our population. We looked at subdural hematomas by age, and 75% of these were in over 60, but there was no differentiation in coding in traumatic versus non-traumatic by age. However, when we looked at fall as a cause of the trauma, we found that as the age increased, fall accounted for 94% of the traumatic subdural hematoma coding. This is critical as most of the falls in elderly are ground level falls. They're not major trauma. And because these patients are elderly, because they are undergoing anticoagulation therapy, that quote unquote traumatic subdural hematoma can initiate the cascade of chronic subdural hematomas. So even though they are coded as traumatic, they are essentially within the target population of chronic subdural hematomas. Then when we looked at, based on the 3-year data from our primary service area, for which we get 97% of the patients, and we extrapolated it to the US population, we found that all subdural hematomas, traumatic and non-traumatic, the incidence was 59 per 100,000 person per year, or just under 200,000. All non-traumatic subdural hematomas were 26 per 100,000 per year, 84,000 cases. That by itself is a significantly higher disease incidence and matches what is reported in the literature. But when we add the traumatic subdural hematomas over 60 in patients in whom fall was the cause of the traumatic coding, because we feel that is an inciting event, then the disease incidence is 44 per 100,000 persons per year, which is more than the large vessel strokes from the same population at 31 per 100,000 persons per year. So What that tells us that this disease has a fairly large scope, possibly larger than large vessel strokes and M2 occlusions, existing somewhere in this range between 31 and say 50 per 100,000 persons per year. So a fairly large target population. And when we look at thrombectomy procedures from 2015 to 2021, we see a significant growth in the first few years and a relative flattening in the current years. This is actual data based on multiple sources. The reason I'm showing that is because we can use this growth phase to somewhat map what could happen in the MMA embolization procedures. When we map that out for the next 10 years, going out to 2029, and we use a 12% growth rate for endovascular therapy for stroke, which is fairly aggressive because we're seeing relative flattening. But if we use the same trajectory that happened to endovascular stroke therapy after this treatment was shown to be efficacious, we can see a fairly high growth rate and actually fairly high overall disease burden that could be higher than endovascular stroke therapy, and this could become a dominant endovascular procedure if these clinical trials are positive. We also compared MMA embolization versus standard management in our own population prior to initiation of these clinical trials. The control group was similar to the group that underwent MMA embolization, over 40 non-traumatic mixed density chronic subdural hematomas, over 1 centimeter in thickness, with the primary endpoint of % reduction in hematoma volume. There were 77 cases in the MMA and 96 in the control group, and majority of these cases were treated with NBCA. 10% were treated with Onyx. There was no difference in age, gender, admission, GCS, or initial hematoma volume. There was a slightly higher incidence of atrial fibrillation in the control group. However, there was no difference in antiplatelet or anticoagulation medication. And we find that there was significantly higher reduction of hematoma volume in the MMA versus the control group. And you can see a relatively tighter spread compared to the control group as well. When we separated it based on patients who underwent surgery versus no surgery, we see the biggest difference in the patients who went MMA embolization as primary therapy without adjunctive surgery, with a 70% reduction compared to 36%. And in the surgical group, we had a 90% reduction in the MMA group versus a 75% in the surgery alone group. The rebleeding rate was also significantly lower at 3% in the MMA versus the control group, no rebleeding in the surgery plus MMA group, and significant difference, the most difference was in the medical arm, 6% rebleeding versus 22% in the medical arm. So this is an example of a typical case of an MMA embolization in a patient with subdural hematoma. This is a traditional transfemoral access into the external carotid artery branches. This is the middle meningeal artery. This is selectively catheterized with the standard neurovascular techniques using a microcatheter and wire. In this case, this is placed in the frontal division of the MMA. This angiogram shows the distribution of that blood vessel to the anterior portions of the meninges, the dura. And after that, we prepare the NBCA. In this case, we are preparing a 20% mixture, which is one of NBCA, which is glue, with 4 of ethylidol, which is the oil that it is. The glue preparation is fairly meticulous, and after that, we prepare the microcatheter, bathing it with D5W, and then inject the glue. So you can see that 20-25 minutes of the procedure, 30 minutes of the procedure are just in access and preparation, and the actual glue injection is very fast, perhaps 15 to 20 seconds. So we can see the microcatheter in the frontal division, and here is the glue coming out on the lateral and the A plane from a wedge microcatheter position without a D5W push. with the good coverage of the branches arising from the frontal division. In this case, the hematoma was mostly localized to the left frontal convexity, but there is some retrograde filling of the parieto-occipital branches, and the microcatheter is then removed. This is the glue cast following removal of the microcatheter, and then we do a catheter angiogram showing the occlusion of the frontal division branches. This is another case that I showed in the beginning. This patient has a typical chronic subdural hematoma, multiple membranes, acute, subacute, and chronic hemorrhage on both sides, obviously larger on the right side, with significant mass effect midline shift, but also smaller subdural hematoma on the left side. It measured almost 3 centimeters on the right, measured about 15 millimeters on the left. The right side was evacuated with sepsis drain in place with significant reduction in the volume. The left side was not evacuated. This is a glue injection on the right side from a wedge position. This is in real time with significant good penetration of all branches of the middle meningeal artery and good coverage along the entire cerebral convexity, because we don't want to limit it to a small portion. This is the injection on the right side from the parieto-occipital branch. Again, good retrograde filling of the branches, not only the parieto-occipital, but coming down to the frontal division. In this case, most of the hematoma was along the right parietal and posterior frontal convexity. This is the 3-month follow-up showing resolution of hematoma bilaterally. So patient had surgery on one side plus MMA embolization and just MMA embolization on the other side with good injections on each side. And this is another example of hematoma measuring just over 1 centimeters on the left side, no real midline shift, no evacuation was performed. This is the microcatheter injection in the parieto-occipital branch and in the frontal branch. Often we see arteriovenous strengthening, which is not a sign of arteriovenous fistula. It's just because the membranes are hyperemic and there is a rapid transit time. In this case, the injection was just performed in the frontal division, and compared to the first injection I showed, there is very limited cross coverage across the membrane, and this hematoma did expand over the next 3 months. So that is why these trials are important in showing whether the treatment is beneficial. And what this also shows that the quality of injection can have an impact. In the first case that I showed where the hematoma resolved, we see extensive coverage of the dura on the lateral plane. If you count the number of boxes where you see the NBC embolic, you can see that almost all the frames are filled, whereas in this case, this is only limited to 3 squares and much less extensive coverage of the hematoma, of the subdural membrane in the second case, which did recur. So in conclusion, is MMA embolization here to stay? Well, first of all, the potential target for MMA embolization is large. And if the therapy is helpful, we can potentially help a lot of patients, especially as our population ages, and especially our largest growth curve is happening in the elderly over 70, in whom this can be a real sentinel event. MMA embolizations could become dominant if the clinical trials show benefit. That is the big if. Early data shows some signal in favor of MMA embolizations. The signal is certainly higher for the medical arm group because with less invasive techniques such as sepsis, evacuation of these hematomas is a great way to minimize the burden of the disease. Different embolic material may give the same result. We don't know that. We have to wait for the trials to conclude. And the quality of injection could also determine outcomes, and that all will be teased out as these trials conclude and we find out A, if there is a significant benefit of this treatment, and B, what kind of injection, whether unilateral, bilateral, what kind of material may help. At this point, I will stop and take any questions. And again, I'm appreciative of the invitation, and again, congratulations on hosting a very successful meeting with great relevant content. Thank you.
Thank you, Ansar. Can you hear us there?
Yes, I can hear you.
Thank you for making yourself available, man. Very, very kind of. Any questions for Dr. Rai, guys? Abby is telling me we have 4 minutes for questions.
Sorry. Demetrius here. Quick question regarding the cost of the procedure in effectiveness. So, like, you know, we're talking about one catheter, different embolic materials, different prices. Any evaluation on that at this point, using balloon catheters, you know, 2 microcatheters, different costs of embolic? When you start losing the benefit of this, obviously, between the more effective embolization versus the cost of the procedure and how effective it is?
Yeah, hi, Demetrius. That's a good point, and that comes up often. I mean, PVA and particles are the cheapest. NBCA is fairly expensive, I think, as is Onyx, and these will be priced similarly. So I don't have a good sense of the cost effectiveness in terms of quality of life and long-term outcomes. And I'm not even sure if one embolic agent will be better. We think that a better penetration with visible penetration using say NBCA or an Onyx is better, but I have heard a similar argument from people who use PVA with that you can get the same kind of result. So I think it remains to be seen. Certainly, if the trials, I mean, we went through Sampras with a lot of hope, and so we just need to wait and see if these trials are positive. And I think the cost effectiveness will be able to figure it out later. I think the procedure overall is less costly than an endovascular stroke procedure. I think it's less costly material-wise, direct cost-wise, but also the logistics and the infrastructure required to do the procedure in a non-emergent way compared to stroke, and that's why it could become a dominant procedure. But I don't know exactly cost saving wise in terms of a true cost effectiveness analysis if this is better. I think that if we do see a big difference, it'll be in the medical arm, less so in the surgical arm, because if we can prevent readmissions and other readmissions related to not only just the hematoma but comorbidities, that will make the procedure more likely to be cost effective.
Answer, thank you. 30 seconds answer the next one. Now we have the time they're cutting us here, but we need to know local versus general anesthesia. What is your thought on that?
We do general anesthesia. We started with local, but I think it's critical that we clearly see where the embolic is going. So we do general.
I was gonna say a joke, but I'll refrain. My frontal lobe did activate this time. Thank you, man. I really appreciate.
One question here.
Oh, hold on. There's one more from Zoom. I'm sorry, and we'll let you go. I see your scrubs are ready. I know what your plans are for the next hour.
Yeah.
Your microcatheter of choice. The question here is about detachable tip microcatheter. Do you use that on these cases?
We use the Headway Duo, or is the 17 Headway 17.
Thank you. Hold on. Seniority here. AJ has a question.
Santa Claus here. So quick question, very provocative thought. You have so much data on epidemiology in your region. Is there a group of patients that are anticoagulation, have often frequent falls, have these little subdurals? And we know from repeated surgery that these patients don't do very well cognitive. Preventive embolization of both MMAs, low morbidity of the procedure. Is that conceivable?
Well, I mean, if we look at the endovascular stroke trials, which started with very strict inclusion criteria, low core, high NIH, good baseline pre-morbid condition. And now when we look at it, that it's evolved into, large core, et cetera. I don't know if we will do preemptively before we even see the disease, but if the trials are overwhelmingly positive, I think we can see treatment of most of these early on in the first setting. I don't know if we're to the point where we can do it before the hematomas even appears, because the incidence is still 20 per 100,000, and in that high risk population the incidence is higher, but I don't know if we're not there yet at the preemptive embolization part.
Thank you, Ansar. Really appreciate, my friend.
Thank you.
Great weekend.